enough time
Great.
not only to go ahead and to present the seminar, but also for some time for discussion. It's not a formality to express appreciation for Cliff being willing to join us today. Cliff's an incredible person. He's a friend and colleague for a number of years, was instrumental in terms of a partnership that resulted in the development and now the renewal of the NNE-CTR. But what you're going to hear today is really the product of somebody who is a physician scientist who has done an awful lot in terms of the treatment of osteoporosis, developing clinical trials, and a mechanistic program in his laboratory that dealt with stem cells and the various options that stem cells have, particularly the decision between adipogenesis and osteogenesis. But what he's going to talk about today illustrates how he really captured the necessity to be responsive to the pandemic. And he really was involved in two things that have made a difference locally and beyond. One, being in a strong leadership position for the N3C initiative. In other words, capturing the power of data science and utilizing it to understand what we're confronted with and how we can extrapolate from the experience we are now facing, and to be able to use that in terms of lessons learned for the future. And he's done an awful lot in terms of trying to understand what we're confronted with the post-acute complications of COVID. So I enjoy working with Cliff on a daily basis.
Thanks, Gary. I appreciate the introduction. And
that's not the introduction.
Oh, that's it. That's it. You got to have time for questions.
That's my 15 minutes, but Katie has 20 minutes.
Yeah, sorry, Cliff, to steal the spotlight from you. But while you're getting your slides together, I'll just mention that we're going to have a Q&A at the end that my colleague Andrew will moderate. My name's Katie Modal, if you don't know. And on a personal note, I'll just mention that Cliff is a fantastic mentor and colleague, and we're very lucky to have him. I think many of us can say we owe career success to him. So thank you, Cliff, for being here.
Thanks, Katie, and thanks for being involved in the CTR. Yeah. So I'm going to talk about
but you know, I was going to call you today. They came to put a new rotor in.
Uh-oh. Somebody else is
talking. We'll work on muting people. Go ahead.
All right. So where are we 3 years out from the COVID pandemic? I want to preface my talk by just saying that the CTR has been an instrument to allow all of us to expand our science. And thanks to Gary, Jane, and the group at Vermont, and Gordon as well, we really have put together a program that is a structural framework for research. And I think Gary would agree that when we started, that was our goal, to provide a framework across Northern New England to do clinical research and to provide a research infrastructure that allows us to get into communities and to deal with things that are important for the community. And I think as I've sort of enmeshed myself in the long COVID problem, I've realized how very important this is to the community. There's huge need out there, and it's not just in clinical practice, but it's in every individual who is affected with this syndrome. The need for information, the need for clinical trials. So what I'm going to do today is just give you a brief overview of acute COVID-19 as a setup for why we think that's important in defining some of the long COVID syndromes. And if I'm not definitive in the question and answer period, it's because we're not definitive about what long COVID is. We have ideas, we have a syndrome complex, but it's never been fully defined. So as I said, without the CTR, we would never get into RECOVER, which is the 4-year longitudinal cohort study of individuals with long COVID, as well as asymptomatic individuals without disease, but with infection, and those that were not infected. And my partners in crime, Sally Hodder and I, are the multi-PI for this network, which we call the I-SCORE network, which is Maine, Vermont, and the states in dark green as well as light green. And that's partnership with some CTSA members as well. And Phil Kern, John Kerwin, and Phil Scherer are also partners that I'll show you about in another grant that we're doing to try to understand the pathobiology of long COVID. So with that introduction, these are my conflicts of interest. And I will say that I get a sort of a voyeur's view of long COVID papers because I'm the editor in charge of long COVID manuscripts in New England Journal. So I have a chance to really see what's coming in. And for the most part, we haven't published a long COVID intervention study or a important epidemiologic study because the quality of the work so far to date hasn't been as good as we had wanted. I'll show you some examples, though, of some hints about what the prevalence is and what the syndrome complex is, and then what we think we can do about it. So first, just a little bit on acute SARS-CoV-2 infections, and then I'll talk about patho-physiology and research efforts through the CTR. So just to remind you, this is the nucleocapsid protein that surrounds a large messenger RNA for SARS-CoV-2, and antibodies to nucleocapsid define a previous native infection. The spike protein is the other well-known antigen on the SARS-CoV-2 virus, and antibodies to the spike protein are seen in individuals who are infected, but also individuals who have been vaccinated with the mRNA spike protein derivative, which is currently in the United States. So a very big virus, and it attaches to tissues, many tissues, primarily through the ACE2 receptor, which you're mostly familiar with, but also through a serine protease, TMPR SS2, which can actually cleave the CoV-2 spike protein and the S2 domain and allow entry of the virus where replication occurs. There's thought to be other pseudoreceptors or receptors that can bind to this spike protein. You can imagine something that's sticking out on the cell surface is going to bind to a number of other things. And keep that in the back of your mind, because I'm going to talk a little bit about molecular mimicry as a mechanism for a potential long COVID symptomatology. Okay, so I'm sure most of you are familiar with the acute infection. There's a rapid inflammatory response, and it's quite dramatic. Release of TNF and interleukins, as well as pronounced oxidative stress. I think if you had to say one thing that was more global in terms of the body's response or the body's characteristic, it's an endothelial inflammatory condition. So the vasculature is very reactive, in part because of the ACE2 receptors, but also because of the approximate closeness to immune and inflammatory responses. But unlike some other viral infections, there's a period of prolonged immunosuppression which occurs. And this is one of the things that has bedeviled not only acute COVID, but long COVID. There's no question that you can treat the acute cytokine storm and inflammatory response with specific antibodies to IL-6 and TNF-alpha, and also by high-dose dexamethasone. But what happens to the innate immune response? And the adaptive response is generally fairly strong, but the actual progression to T-cell responsiveness and its ability to kill virus and also to persist in the system, the inflammatory nature, is something that has to be explored because it almost certainly contributes to long COVID symptomatology. Okay, so just to quickly remind you that the lung is the primary site of infection from the nasal epithelium, and you get an initial ground glass opacity type phenomena with COVID-19 pneumonia. This can progress to ARDS, as you can see, with fairly significant destruction. And ultimately some pulmonary fibrosis, even in mild cases of pneumonia. And this pulmonary fibrosis is actually very relevant because as you progress to long COVID, those that do, fibrosis is a feature of the dyspnea and fatigue of long COVID patients, particularly those that have been on ECMO or on respiratory support. And we'll come back to fibrosis and its relationship to glucose intolerance in just a few minutes. So there's impaired oxygen exchange, and there's a tremendous increase in fibroblastic infiltration that leads to the fibrosis. And that fibroblast inflammation is reminiscent of what we see in obesity. And so the intimacy between obesity and pulmonary fibrosis is one of tremendous interest to us in terms of the pathogenesis. There are a number of cardiac manifestations of acute SARS-CoV-2 infection, principally again through the ACE2 receptor and dysregulation of the angiotensin renin circulating system. And this can lead to both heart failure, arrhythmias, thromboembolism, and pericarditis, and certainly in children, the very acute inflammatory response that leads to hospitalization in the subset of children who develop this as well. And in addition to that, possibly longer term damage to the autonomic nervous system and to the response to postural changes. And we'll talk about that in greater detail. So the CNS is not immune to the virus. It's not clear that the virus lives in the brain tissue itself. A couple of the autopsy series suggest there may be viral remnants there, but there's a dramatic inflammatory response, and that is because the virus enters through the olfactory route, which is very close to the brain, but also because of that vascular endotheliitis, which is rather pronounced on autopsy series as dramatic inflammatory response, which can open the blood-brain barrier to the possibility of viral entrance. And there may be some lung to CNS connections as well through neurotransport. But CNS changes in the brain occur in acute SARS-CoV-2, but as you'll hear, they're much more common in long COVID, and they're manifested by things such as memory loss, brain fog, fatigue, and other complaints. So acute hyperglycemia is frequent in acute COVID, and this is related both to the significant outpouring of cytokines, but also the glucocorticoid treatment of these cytokines, which can lead to marked impairment in glucose tolerance. So insulin resistance is a very common feature in hospitalized patients. And it's probably related to two things, both insulin resistance at the peripheral level in fat tissue and at the islet cell level in the pancreas, where there may be a transient impairment in islet cell secretion. These are things that still need to be confirmed, but we do know that the peripheral fat resistance syndrome, insulin resistance syndrome, is clearly much worse in diabetics, particularly type 2 diabetics. And so the severity of acute SARS-CoV-2 is directly tied to body mass index and previous history of obesity, as well as type 2 diabetes. And this occurs for a number of reasons. Most predominantly is that same post-inflammatory fibrotic response we see in the lung. We see a similar pattern in fat tissue, particularly visceral fat, where you get the recruitment of macrophages around an expanding adipocyte. And this leads to a long standing process of chronic inflammation, increased leptin production, and activation of immune cells, which can ultimately recruit fibroblasts that can lead to a fibrotic type stroma around the adipocytes. Some recent work has suggested that there's lipid abnormalities in acute COVID, and the reason that may be important is because it may ultimately predict individuals that go on to develop long COVID. That is, high triglycerides and low HDL have been patterned as one acute phase reactant, which may predict those who ultimately develop long COVID symptoms. So, acute COVID-2 is a multi-system disorder, glucose intolerance, insulin resistance, and lipid abnormalities are common. No tissue is spared, but the primary tissues, as you're probably well aware, are cardiac, brain, and lung. So how does this relate to long COVID? Well, first of all, you have a systemic disease in COVID-19 that affects many tissues. So I guess it's not surprising whether the virus persists or doesn't, or if there's antibodies or they aren't, there's still this chronic, there's this acute response, which could progress to chronic disease and to some of the symptomatology. And our job is to, one, try to understand what the definition of long COVID is, and two, try to define what the pathogenesis is. So there are a number of names for this: long haulers, long COVID, post-COVID. We call it PASC, post-acute sequelae of SARS-CoV-2. Since October of 2021, there's been an ICD code for long COVID, and individual patients can be coded as having long COVID by the number U09.9. You only need one symptom more than 4 weeks after the initial infection to be coded as U09.9. So that's the good and the bad. The good is that we get a general idea from electronic health records how many individuals go on to develop symptomatology post the acute infection. The bad news is it's such a vague definition that it's unclear whether we're overestimating or underestimating the degree of COVID, post-COVID symptomatology. So Gary mentioned this, and we are part, and Gary and the University of Vermont are also a part of the National COVID Cohort Collaborative. And since May of 2021, MaineHealth has been contributing data every 2 weeks, thanks to Susan Santangelo and her group at Bioepidemiology Research Division of the CTR. They've been contributing data into the N3C data set, of which we now have probably close to 13 million de-identified individuals, where it is open access for individuals that go through the approval process to try to understand, using large databases with EHR records, what the pathophysiology is, what the epidemiology of acute and long COVID is. And in this recent paper that was published through using the EHR code for long COVID 09.9, the authors in our groups produced this sort of set of clusters: the cardiopulmonary cluster, the neurologic cluster, and the metabolic and obesity related cluster. These are the three big features of long COVID, and I'll focus on those shortly. But this gives you an idea, based on the N3C database and longitudinal follow-up of individuals with acute COVID, what happens to their symptom complex, and potentially what is the frequency of this. So this is work from a paper that we just submitted to Lancet Public Health. And in there, I was working with a group called Inference, which is a company in Cambridge, Massachusetts, partially founded by George Church and the Harvard colleagues. And they have used artificial intelligence to try to identify both modeling of the virus and viral complex symptomatology, as well as our initial attempt with them to get at post-COVID prevalence. So the key to inference is they have almost 1 million de-identified records from the Mayo Clinic that they can work with, and they're longitudinal, so they have data on individuals before they get infected, during the infection, and then post-COVID. So almost a unique way of looking at what how the individuals develop long COVID. What's the percentage, and are there predisposing factors? And in this paper under review, we noted that cough, difficulty breathing, and tiredness were major symptom complexes. One of the strengths of this type of work is you have pre-COVID data sets. And I'm going to come back to this issue because it's very relevant to studies that are done cross-sectionally. And in part, that's because we know from our work in Recover, where we recruited 110 patients from in the southern Maine area, that there are some individuals who had symptom complex prior to infection, and then it's aggravated by COVID. And so having to take that into account is extremely important in order to determine the true prevalence of long COVID. Anyways, we identified those symptomatologies in this study. And for the most part, these were not hospitalized patients. So even dyspnea continues to be an issue for non-hospitalized patients that have not had lung support artificially, but still have been infected primarily with the pneumonia complex. So this is a very recent paper from Italy in which they looked at the prevalence of past symptoms in an Italian cohort. And again, dyspnea and fatigue and insomnia are upwards of 30% for dyspnea and fatigue. But the most important thing about this paper actually relates to the timing of symptomatology relative to the viral variant. And that is true, we think, because we're seeing the same thing, that brain fog and fatigue and myalgias and anxiety and depression are much more common post-Omicron than they were with Alpha, Beta, or Delta. And in fact, we rarely see anosmia as a chronic complaint in long COVID in post-Omicron infected individuals. In individuals with the early variants, anosmia was a persistent and long-standing complaint, and we just don't see it. And they've reported this as well in this paper. So one of the things that really shook up the NIH and all of us really is this paper in Lancet Psychiatry earlier this fall, in which they did EHR records on 1.3 million patients across the United States, Europe, and Asia. And what they were doing was comparing the rates of post-viral infection symptoms beyond 4 weeks, any post-virus, primarily influenza, relative to SARS-CoV-2. And what they found was a much greater risk of cognitive disorders, anxiety, and psychotic disorders in those individuals who were infected with COVID, SARS-CoV-2, rather than those with influenza. And then in this recent submission to the journal, the group at UCSD looked at neurocognitive function in individuals with long COVID symptoms and compared them to the pre-Omicron infection. And you can see that although there was greater return to work with Omicron, there were more of the symptoms related to headache, difficulty concentrating, and clouded thinking, suggesting that we're dealing with a different type of post-viral response in the body to those with Omicron virus. Now, this paper just came out this week, and I wanted to highlight for you something really important, and that is that these individuals were in a longitudinal study of in the INSPIRE group, in which they used PROMIS short form measurements to look at scores related to anxiety, depression, fatigue, sleep, and pain interference. And what they showed was that at 3 months post-infection in those individuals, there was marked improvement in the symptomatology, which we see as well. The longitudinal evaluation of long COVID symptoms includes a group of individuals who definitely get better after 3 months. But what they also showed was that in the control group that was not infected, the response was almost identical. That is, there was an improvement in symptomatology. And this comes back to this issue of having to know exactly what symptoms were present before they were infected. And so what we've had to do in the National Recover Project is add a question about how these symptoms relate to symptoms prior to infection with SARS-CoV-2. So this is extremely important and highlights how running a clinical study, even an observational study like this, in an area where we're learning every week what's going on is extremely difficult, because much of Recover, besides the lab work and the x-rays and the CT scans, relate to questionnaires, not just about their overall health, but their socioeconomic status, their relationship to others. And so those questionnaires become extremely valuable in order to really fully define the incidence of long COVID, which is one of the goals of the Recover Project. So with that in mind, and with the statement that we still don't know the true prevalence, we would estimate, and it's changing every week, somewhere between 10 and 15% of individuals who have had acute SARS-CoV-2 infections will develop symptoms after 4 weeks. Many of those will go on to clear those symptomatology, but a subgroup will not. That exact subgroup, how we can identify them, what we can do about them, is really the subject of ongoing research, and the importance of research. And again, the importance of an infrastructure such as the CTR, which allows us access to clinical studies and to propose newer pathobiological examinations. So I would say that the two most likely mechanisms, and the one that's sort of the third for the post-COVID symptomatology, include viral persistence, hiding out a virus somewhere. 2, reactivation of Epstein-Barr virus, antibody reactivation, which contributes to chronic inflammation. And the third component is probably autoantibody production, which can lead to, again, chronic inflammation and targeted system-related complaints. So this paper is out 2 weeks ago in JCI, and it came from the UCSF group, Mike Peluso and colleagues, and they looked at individuals who were infected with SARS-CoV-2 that did not have symptoms, which is a good control group, long COVID, and long COVID with greater than 5 symptoms. And I sort of laugh at this because Yvette Emery and our group developed a similar sort of grading scale, which I'll tell you about in our cross-sectional study. And so you can grade on the degree and the frequency of symptoms, and also the magnitude. And I just want to point out to you that obviously there are some risks associated with long COVID symptoms, but I want to highlight for you in the grayish area that HIV, previous infection with HIV certainly increases your risk of neurocognitive symptoms, but also the higher antibody titers for EBV, NA-IgG, greater than 600 are associated with more neurocognitive symptoms, whereas CMV titers of antibodies are associated with a lower risk of neurocognitive symptoms. So what do we make of this? I think we are worried that Epstein-Barr viral reactivation or reactivation of the immune response to that virus may be contributing. And the reason we're so worried about it is because many of the symptoms of long COVID resemble those of chronic fatigue or myeloencephalopathic syndrome, which is thought to be post-viral, but nobody really knows for sure. But it's concerned us enough, the resemblance of the fatigue and the malaise and the neurocognitive symptoms, that additional questions have been added to our Recover project to screen for those symptoms using a validated questionnaire for CFS. This is some really beautiful work from P.J. Utz at Stanford, in which he looked at autoantibodies to different cytokines in acute COVID-2 infections, particularly severe COVID-2 infections. And you can see that there are marked increases in titers for a number of different of these antibodies. And his point is just that, including ACE2, and that his point is only that autoantibody production occurs during acute infection. It occurs in non-SARS-CoV-2 infections. Does it persist? Are there specific antibody complexes? He has a multiplex system, so he can look at that in long COVID. It's one of the long COVID pathobiology grants that have been funded, just starting to get funded. Okay. So what about this brain fog and neuroinflammation? I gave grand rounds in neurology yesterday, and everybody, they're one of the most responsive groups because they're seeing all these patients. And when I showed the cluster complex, they sort of laughed and said, all these complexes are related to neurocognitive function. And this is what they see. There's no evidence yet that there's virus that's hiding out in brain tissue or the subarachnoid space. But there is evidence from autopsy series on both long COVID and acute COVID that there's a very pronounced microglial inflammatory response that can drive changes in neurogenesis and oligodendrite life. And this group that was featured in Cell recently suggested that one cytokine, chemokine, CCL11, was higher in individuals with a brain fog and a history of autoimmune disease. So another feature in a paper that I was just asked to review, but I haven't had a chance to look at it, was from our colleagues at Case Western, where they're seeing an increase in the frequency of type 2 diabetes out to 90 days 90 days after the 4 weeks of infection and recovery. And that frequency of that increased risk is between 2- and 3-fold. And there clearly is insulin resistance. In a paper we published in eLife earlier this year, we summarized some of the preliminary data. I think this case data is as good as anything else. And type 2 diabetes and or glucose intolerance is a relatively common, maybe 30% of long COVID patients have some form of insulin resistance. And that's likely due to fat cell inflammation around fat cells. But I will just remind you that the spike protein and the S protein both have characteristics that resemble other antigens, native antigens in our body, including islet cells and the islet cell autoantigen, which looks very similar to spike protein, as well as thyroid autoantibodies and thyroid peroxidase in particular. So it was not surprising to think about the fact that if you have molecular mimicry, that you can turn on thyroid antibodies and develop subacute thyroiditis in response to a previous infection with SARS-CoV-2. And we know post-viral thyroiditis does occur generally. We know long before COVID-2 came on board, but this relates to the possibility that the fatigue and tiredness that individuals see may be a phase of subacute thyroiditis associated with hypothyroidism. So our colleague Jonathan Lee, who's part of our research group he's at Harvard, he's published a number of papers showing that there's viral persistence, and this is by measuring the viral mRNA by QRT-PCR, and he's shown that in not just the lung in blue, but the spleen, the heart, the liver, there's evidence of virus, and that evidence is during acute infection, but also, as he showed, it's also there in longer-term individuals who have developed acute SARS-CoV-2, some of whom have developed long COVID symptoms, and particularly the autoimmune or severe immunocompromised patients have a fairly significant delay in clearing SARS-CoV-2 from their system. And again, these are plasma samples. So one of the breakthroughs, I think, of 2022 in SARS-CoV-2 is the development of the Samoa assay for SARS-CoV-2 antigens. And this was developed by David Wald, who's a colleague of Jonathan Lee at Harvard. And he was able to develop a microwell array, which allows him to test using beta-galactosidase and streptavidin to actually measure titers of the antigen, not the RNA, but the antigen itself in the circulation, in plasma. And as I mentioned to you, the antigens that we're interested in are the nucleocapsid antigen, the spike protein, and the S1 antigen. And as you can see in this paper that was published a month ago in Journal Clinical Infectious Disease, the S1 antigen is not really detectable in individuals with long COVID 10 months out. But if you look at the spike protein, you can see that it's still detectable in the plasma in fairly reasonable concentrations, picograms per ml, in patients who have long COVID. And much more so than the nucleocapsid, which I guess is not surprising since it's interest within the virus, whereas the spike protein is outside. Now, the clinical significance of this is unknown. Is this impaired clearance? Is this just the protein that's cleaved off the virus? Is this the virus actively replicating and spitting out spike protein? We don't know the answer to this. But our friends at Stanford, Catherine Blish, Tracy McLaughlin, published in September a great paper where they looked at immune infiltration in adipose tissue from autopsy samples of COVID-19 patients. And what they found was not just this large macrophage infiltration, but actually by in situ hybridization from the epicardial fat pad, significant virus. And so they have, and then they did single cell, and they looked at different inflammatory markers, both in macrophages and pre-adipocytes following infection with the SARS-CoV-2 in the laboratory. And it's clear that it sets up a huge immune response in fat cells, and that if the virus is in fat cells, the inflammatory response is principally, according to this group, and we've been working together with them on this new grant, it's principally related to macrophage release of cytokines and chemokines that drive the inflammatory response. So think of it as infection in the adipocyte, response by macrophages around the adipocytes that are releasing these adipokines. And that comes back to the issue of fibroinflammation, and work from Phil Scherer and his colleagues over a number of years have shown that unhealthy obesity is associated with a chronic inflammatory response around adipose tissue, which includes the differentiation into lipofibroblasts, which are much more fibrotic and contain lipids. And these are also present in lung tissue. And in work from Amit Gagar at the University of Alabama at Birmingham, he showed that one particular fibrotic protein, collagen 6A3, was highly expressed in the autopsy lungs tissue from SARS-CoV-2 infections compared to those with influenza. So collagen 683 is made by fibroblasts and adipocytes. These are the only two sources of collagen 683. It's then cleaved to a compound called endotropin, which is a peptide fragment, and endotropin circulates and can be measured. And Phil has the assay for endotropin, and this protein is related to a number of chronic conditions and chronic inflammation, including heart failure, stroke, and chronic kidney disease. And so work has been ongoing to see if this is a marker, not just of inflammation, but of this fibro-inflammatory response, particularly in obesity. And as you can see here, the MMPs can cleave collagen 683 to lead to endotropin, which drives fibroinflammation, but it also drives insulin resistance and glucose intolerance. And that's been one of our underlying hypotheses, that with this fibroinflammation, with viral persistence, that you get this insulin resistance or glucose intolerance. And some recent papers have shown that endotropin can be a measure of glucose control and also of albumin excretion in type 2 diabetics. This is some unpublished work from Phil Scherer, in which he looked at metabolically healthy individuals, metabolically obese individuals who were healthy, and then the metabolically unhealthy, insulin-resistant individuals. And you can see a step up in the concentrations of endotrophin in the circulation, suggesting that this chronic metabolic inflammatory condition that we think of as type 2 diabetes or insulin resistance may be associated with higher levels of this peptide. And because of that, we started a collaboration with a group at Tulane, which is part of our iScore network, to look longitudinally at individuals who had recovered from acute COVID and that were being followed. And as you can see here, in some brilliant work from UNE medical students who helped analyze this data, we found that those individuals that were on high levels of oxygen during acute hospitalization had greater levels of endotropin at 90 days than those that did not, suggesting that maybe the pulmonary infiltration and fibrosis was contributing to higher concentrations of endotropin. And I'll just give you one patient as an example. This individual was quite sick with acute SARS-CoV-2, had very high levels of endotrophin, subsequently went on a number of different treatments, including hydrochloroquine, lopinavir, and ritonavir, and got better over time and did not require oxygen. And his endotrophin levels came down nicely. But he subsequently reappeared with dyspnea and some pulmonary fibrotic changes requiring oxygen. His endotropin levels went back up, and subsequently he's better now, and his endotropin levels are down. So it's an N-O-1, you take it with a grain of salt, but this is the basis for some of the work we're doing in our new study, which is the PROMISE study. It's called the Pathobiology and Recovery of Metabolic and Immune Systems. So we applied for this in January of 2022, along with 200 others. And we were very fortunate in July to be notified that we were one of 18 centers that would be funded through the NIH to do this study on the pathogenesis of long COVID. And so we teamed up with members of our iScore network. And again, all this is because of the CTR. John Kerwin at Pennington with the LSU CTR, Phil Kern with the CTSA at the University of Kentucky, Jonathan Lee and David Walton, I mentioned to you previously, from Harvard. And our idea was to try to determine the extent of adipose inflammation and glucose intolerance, as well as cytokine release in long COVID. And then, thanks to some beautiful work from John Kerwin at Pennington, test whether T cells are fatigued in long COVID. They're not working as well as they should be. And we have hypothesized that that is related to viral persistence and the chronic inflammation. So that's our hypothesis. Individuals who don't recover have persistence of virus in adipose tissue, and the response is due to or the symptoms are due to the impaired response of interleukins. And Sergei Ryzhov at our institute is one of the collaborators with us and will be doing some of the T-cell work. But it's a shared effort from the 3 centers and Harvard. And this is the work that's unpublished from John Kerwin, showing that oxidative phosphorylation is impaired in long COVID subjects, much more so than the glycolytic component. And we think this is a direct effect of viral persistence on chronic stimulation of T cells, leading to T cell fatigue. But in addition to that, Sergey and Dave Cedar and the group at MaineHealth have also shown that CD26, which many of you may know as DPP4, for which treatment with anti-DPP4 is used to treat diabetes, that DPP4 is higher in patients who do less well during acute COVID, and may be a persistent marker of chronic inflammation and prolonged viral presence. So we'll be testing that as well. There's some data that CD26 is a receptor for the spike protein, but I think it's still debated. So our approach is a case control study in which we'll get 40 cases that are highly symptomatic. All these individuals in this study will have been infected with acute SARS-CoV-2. And we have documentation of that from the Recover Project. So we know exactly when their PCR test was positive, and we know that they are positive. We're testing really the question, why don't people recover from long COVID? So we're taking 20 controls from the 3 states that have had acute SARS-CoV-2 but do not have symptoms, and comparing them with 40 cases of those that had symptoms. And you can see in this diagram that most of our individuals in our main Recover Project have at least 1 to 3 symptoms, and we're using as a screen 6 symptoms or more. And this is beautiful work, and I just want to say it's hard to read this, but if you think about symptom complex in long COVID, it's both the number of symptoms and the magnitude of symptoms. And in the darkest color are the magnitude of symptoms. There's a range of symptoms from malaise, anxiety, fatigue, pain, and quality of sleep, anxiety, and this complex was developed by Yvette Emery. It's brilliant work in terms of screening our individuals so that we can use this to then select the people above the line that had multiple symptom complex and compare those with those that don't. Just another point, the lower bar below this line are individuals who have not been infected, but still have symptoms. And again, that relates to the possibility that we need to understand what happened before they were infected, and whether those are a continuation of pre-COVID symptoms. So what about therapeutics in the final minute? Just to tell you, we published this paper with Kathleen Fairfield and Kim Murray at MaineHealth as part of the N3C. Vitamin D does nothing for acute COVID, does not reduce length of stay. If anything, it increases it. And that's probably because people have used vitamin D as a last-ditch effort to try to treat individuals who are quite sick. So it's confounded by indication. But the bottom line is it doesn't improve any of the symptoms of acute COVID. Not only that, in this large randomized trial from England, it's just published in BMJ, no treatment, 800 or 3,200 units of vitamin D. It did nothing for infection rate, for symptomatology, for duration of symptoms, or for long COVID. So I think vitamin D is just not useful in SARS-CoV-2. We're starting in January a big trial, not a big trial, but a trial with a group at the University of Mississippi and the iScore network, We're using Imulina. It's an antiviral immune modulator for patients with PASC, and this is a randomized placebo-controlled trial, 400 and 800 units versus placebo for 8 weeks to test whether it increases NK killer cell activity and gamma interferon. So it's a surrogate trial. We're not measuring symptoms, but if there is improvement in some of the immune markers, a larger trial will go on. So we're studying 12 individuals in Maine. And the design, all of them have to have a increased CRP to get into the study. So we want active inflammatory individuals. Just today, this morning at 11 o'clock, I got an email from a group at Ampligen, which has been recently approved for the treatment of chronic fatigue syndrome. It works by boosting NK killer cell activity. You can see that it resembles with this uracil substitution DNA, and it's believed to act on regulating RNase L and also improving killer cell activity. So they're interested in using our site as a center for randomized placebo control. So we are waiting for that further information, but that's another possibility. And finally, I'll just mention that the NIH is soon to embark on a large Paxlovid clinical trial for long COVID patients to see if they can obliterate virus. That would be based on the idea from David Wald that there's still circulating virus, and that 2 weeks of Paxlovid might be enough to improve symptomatology and clear virus. So this trial, we were approached by Duke's Clinical Research Institute, will be a site, but they're still defining the protocol. So it's going to be another couple months for sure. So in summary, it's a multi-system disease, long haulers. We still don't have the true epidemiology, probably 10 to 20%, but I'm not sure of that. The variants, viral variants predict different types of symptoms, which is very intriguing. And there's no treatment, although obviously on the horizon are a number of different interventions. We're particularly interested in why type 2 diabetes and long COVID, what's going on in adipose tissue, how does virus get in adipose tissue? And I have a call at 2 o'clock with the group at Stanford. We've been trying to address this issue of whether virus is truly in adipose cells or actually is in the macrophages, but because of the histology, it looks like in fat cells. So stay tuned. We're not absolutely certain that the virus hides out in adipocytes. We're very excited about the possibility we can use endotrophins as a measure of predictor of pulmonary fibrosis and glucose intolerance. And we're very interested, obviously, in the Paxlovid trial. So with that, I'll stop. And we have about, it looks like between 8 and 10 minutes for questions. So thanks very much for all your attention.
Hello, everyone. I'm going to be moderating the question and answer section. If you have any questions, you can either use your hand or write your question in the chat. We'll start with the hands first. Elizabeth, if you want to ask your question.
Thank you. Hi, everyone. If you don't know me, I'm the Vice President for Research at MaineHealth. Cliff, that was like a fantastic presentation. Thank you so much. I'm curious, you say there's no treatment, but do sometimes people spontaneously recover?
Yes.
Do we know, do symptoms wax and wane? And what is like sort of is it within a year? Like if you...
Yeah, I didn't show you it because it's still under evaluation, but a good proportion of individuals will recover. It takes them 3 to 6 months and their symptoms go away in the generally healthy population. So for example, young males who are fairly athletic, chronic fatigue, really drained out, 3 to 6 months, they're better. Some of the other people with comorbidities, it doesn't get better over the span that we've been following them. And certainly the ones that were infected early with Delta, those individuals still plug along 2 years, 2.5 years later. So it's not clear who the ones are that recover versus those that don't. It's one of the focuses of our grant.
Okay, Carol, you have a question? You're
Thank you. Yeah. So just a simple question, and maybe I missed it because I came a little late. Is there any data about whether the immune responses are always polyclonal, or can they be, or have they been found at all to be monoclonal?
Yeah, it's a great question. I think it's a mix of both. I think there are some monoclonal, and we have a whole battery of data that hasn't been looked at that specifically yet. But yeah, it's both, I think.
And so one of the questions might be whether to use monoclonal antibodies,
Right.
that might
But-
have efficacy for.
But good point. And there is at least one commercial group that is initiating that. So that is another realm of possibility. I think, the issue with the monoclonals is the administration, and versus something like Paxlovid, which is oral, although not without its own side effects as well. But I think the antibody issue is a huge one, and we just haven't tackled it appropriately yet. And that, as I said, it's the third most likely thing. It could be the most important thing. We just don't know because, for example, autoimmune individuals just don't do well with long COVID. Whether that's just exacerbation of previous symptomatology or on top of that, more antibody production, we just don't know.
Gary, you have a question?
Yeah, Cliff, we're now embarking upon another viral challenge. We're hitting the influenza season.
Yeah.
And are there any differences in the symptoms that are encountered by patients who are experiencing long COVID and the flu?
Yeah, so I think the prevalence of long symptoms in influenza is much lower, at least in the variants up to this year. We don't know yet about this year. And in that Lancet Psychiatry study, it was clear that the neurocognitive symptomatology is much more pronounced in COVID, in SARS-CoV-2 infection post-COVID than is influenza. So yeah, there are some differences, and whether that relates to, the pathogenesis from the early stages on, the nasal epithelial introduction and the fact that it can get towards the brain and the neuroinflammation more common. Although at Neurogram rounds yesterday, they presented a case of a person with temporal encephalitis due to influenza. And, it looked like herpes simplex viral infection. And so, all bets are off. I have to be very cautious about this with influenza because we just don't know yet what the underlying sequelae will be.
Okay, so there are a few questions in the chat. First question was a direct question. Is there any indication that COVID can accelerate ALS symptoms?
Wow, it's a great question. I don't know the answer to that. I suspect that it probably would, but I just don't know, and I haven't seen any data. It's worth looking at, but that's a great question.
Okay, the second question from Susan is a great.
I just should mention that there's a lot of parallels in the ALS story that people have thought about in relation to CNS and motor neuron dysfunction in ALS. So with COVID, particularly post-COVID. So.
Okay. Susan says, great talk, Cliff. In one study that was published on December 1st, what was the control group? What did it consist of? In general, are the controls of many of these studies of long COVID usually with those with previous infection but never symptomatic, or no current symptoms?
Right, great question. Great question. So the control group was those that did not have COVID, but they were not excluded because they had symptoms or did not have symptoms. So most of those people had some symptoms such as anxiety or depression, and that's what improved 3 months out. So yeah, but they clearly were PCR negative.
Thanks, Cliff, for a great talk. And thank you everyone for joining us for the fall series. And I'd like to remind you that the spring 2023 series will have a fantastic lineup of topics and speakers. And that will be published in the next schedule will be published on the website and the newsletter shortly. So join us for that next semester. Thank you so much, everyone.
Thank you. Thanks, Gary. Thanks, Sheila, for
Thanks, Cliff.
organizing all this. Yeah.
Sheila.